All right. Good evening, ladies and gentlemen. Thank you for joining us tonight. I've got two special guests, Dr. Yogendra and Dr. Eric Osgood. Both of these are colleagues of mine. We do a lot of long COVID work. And as you all know, we talk a lot about what we do and the difference that we've made in the lives of a lot of the COVID long haulers. We have some really great updates to our program, and I wanted to have them on to talk about what we do with our COVID long haulers. I've been inundated with questions about how our program works, what we do, and we have some very exciting updates. So I'll turn it over to Dr. Yogendra, who will talk to you guys about some exciting updates in our program and what we're up to.
Yeah, thanks, Dr. Bream, and thanks everyone for joining on this webcast. We'll try not to make controversial words like the eye drug and a few others so that we don't get banned or deplatformed. But just to give everyone a quick update, we know that we'll jump into the clinical trial. We'll talk a little bit about that, and Dr. Osgood can sort of talk a little bit more in depth, and then we'll talk a little bit about we'll talk a little bit about the paper, the S1 paper, which is pretty much almost done with peer review. We got some great reviews. We'll talk a little bit about that, and it should be published in the journal by, I would say, if not the end of this month, sometime in December. We're anticipating getting the green light. We got endorsed from all the peer review, whoever it is, because these are blinded process, and all three reviewers endorsed for publication. So we're really excited about that. And then we'll talk a little bit about the vaccine findings, and sort of what that means for the program, and obviously a little bit about the research. So we'll start out with the clinical trial. Obviously, one of the things that when we're talking about long haulers, there's still no consensus on the definition, right? We call it long haul COVID, long COVID, chronic COVID, PASC, post-acute sequelae of COVID. Also the terms when you're still unable to identify or call the pathology or have the disease, you don't have any idea of like what you're studying then. So that's why it's very difficult to run clinical trials, and because you don't know what you're studying, you don't even know what the name of it is. And what we've done in the past, now it's going to be over 12 months, is just been collecting data, immunological data, and now with Dr. Bream, Osgood, Dr. Kreimer, Dr. Parikh, and we've got right now we probably have about 11 doctors now in the program. We've treated and are actively treating over 2,000 patients. There's over 12,000 patients that have registered in the program. It means that they're going through the process of getting the lab work done and signing up and whatnot. But we've actively or treating over 2,000 patients. So we've got this clinical insight to set the framework and the parameters of what would be a clinical trial. Like, what exactly are we studying? What are the endpoints? What are the medications? What are the dosing? So, one of the things is, as clinicians, we have the ability to, using our clinical insight, judgment, acumen, our instincts to guide us in any sort of clinical trial. And that really goes for anything, not just only long COVID. And one of the things we were internally discussing was, how do we put a trial together, and where would we be putting this trial? And right now, we can't disclose the name of the institution because there's just one more signature that does need to come. We were hoping the PR would go out today, but most likely, talking to Chris and Bruce, they're aiming for Thursday morning for the press release to go out. But this is a big academic center in the West Coast. Their chair of medicine has been using the IncellDx kits, has been treating. They have over 1,000 long haulers in their long COVID program. They have been using the kits that Dr. Patterson and IncellDx have developed. And more importantly, they've been using some of the medications and the approaches that we've been studying and looking at. So while we do see very clinical, the benefits of these medications, we do need to prove it in a clinical trial. And that is the logical next step. And thankfully, this institution has stepped up and they are willing to collaborate with us. That press release will go on. Hopefully this Thursday, like I said, one more signature, and we should be good to go. I know internally we've circulated that press release amongst ourselves, and I know we are all extremely excited. So I'm just going to turn over to Dr. Osgood, because I'll sort of just give you a little background into Eric. When Bruce and I put the program together about a year ago, we wanted to bring really just incredible minds and incredible clinicians, and I had the good fortune of collaborating and talking with Dr. Osgood and Dr. Bream and Dr. Kreimer and many of the other physicians on our team. I mean, these guys are honestly just some of the most brilliant clinicians I've ever met and have ever talked to, and I've learned a lot from them. And each of them brings a unique perspective and an important perspective and approach to the program. Dr. Bream, being an ER doc and being in the front lines of active COVID, long COVID, he's brought a lot of clinical acumen and clinical insight. And Dr. Osgood, same thing, and he's got a very interesting background in clinical research. And here's one that really designed the clinical trial. So I'm going to turn it over to Dr. Osgood to really just talk about why he designed the trial the way he did. What are some of the things that he was seeing, and sort of a little bit more about the trial. So Eric, it's all you.
Well, thank you for the very kind words and that very nice introduction. Yeah, so when we were sitting down brainstorming how we were going to go about this, we had some concerns about how can we design a trial that gives us a shot to prove concept, to demonstrate that the treatment regimen that we have been using in this sort of biomarker-driven precision medicine approach, we've been observing what we believe are clinical benefits, but unless in a well-designed trial you can demonstrate benefit over a control group, ideally placebo, with proper randomization and blinding to rule out the placebo effect versus to rule out investigator bias and other systemic issues that might lead a treatment arm to do better than a control arm, other than the genuine effects of the intervention at hand. And we're going to be studying two parallel groups of people when we have likely a very, very heterogeneous population and almost somewhat of a nebulous condition that has not been very well defined. And so how are we going to, without having a massive, huge sample size, how are we going to have enough statistical power to be able to actually show benefit, especially when you consider that a lot of the symptoms associated with this condition are very subjective, and therefore you're going to get a lot of noise around the signal. And so we talked about doing an enriched sample design. And so what that basically means is you're studying a group within a group, and the drawback or weaknesses of an enriched sample is that of generalizability. So if you demonstrate benefit within that trial, can you necessarily generalize it to all comers when it comes to post-acute sequelae or long COVID? But the benefit is if you are actually trying to do a pilot trial and generate what we call proof of concept, show that this intervention, in this case a couple medications, causes symptom and clinical alleviation and biomarker improvement better than a control group or matched placebo, that is a very, very important first step. And so in order to do that, we thought about doing an interesting study design that typically you'll see in an analgesic clinical research called the enriched enrollment randomized withdrawal design, which is something I picked up when we were studying SNRIs for musculoskeletal pain, because this was actually knee osteoarthritis pain and a seemingly homogeneous condition. I have osteoarthritis of my knee. You would think that's pretty homogeneous as far as the causes of pain. It's nociception due to erosion of cartilage, but it turns out that's a condition with a lot of different mechanisms, and not everybody's the exact same. And one of the mechanisms of pain involved loss of normal endogenous analgesia, which is driven heavily by serotonin and norepinephrine. And so we were basically trying to identify enriched samples of patients who based on bedside sensory testing seem to have that mechanism of pain. Versus if you have somebody with more normal nociceptive driven pain, and they don't have pathophysiologic mechanisms of chronic pain, it's less likely they would benefit from, say, like an SNRI. So anyway, like with that in mind, we know that there are very immunologically distinct patterns of post-acute sequelae of COVID. We see that in our program. We do these cytokine 14 panels, and we see slight differences and sort of distinct makeups. Although we do have sort of our somewhat of a classic pattern that we tend to see, but one of them, two of the medications I should say that we use really seem to be at the core of restoring a sort of a non-pathophysiological immune system in response to having viral persistence or S1 subunit persistence after COVID infection, which is basically blockade of CCR5 and blockade of fractalkine, which we achieve with two medications. And because again, these symptoms are so subjective, and sometimes you'll have patients who will sometimes report, no, I don't really feel that much better, but it turns out they are way more active. Their family members will tell you, no, he does or she does seem to be doing much better, more active, better mood, better functionality. And on the other hand, you might have people who are sort of maybe exaggerating how much better they feel, or they're experiencing the placebo effect. And so you can basically get some patients in your placebo group who are improving, and then you can get some patients in your active treatment arm who maybe they're clinically improving, but they're not reporting much improvement. And so you can see how easily your signal gets eroded unless you have a fairly large sample size, which obviously can be a challenge in terms of cost and funding. And so in this study design, basically we have an initial open enrollment or open label phase, I should say, where the research subjects know that they are getting the active treatment. And what we do is around probably anywhere between the 3 to 5 week mark, which is generally when patients on this regimen will start to feel better. At that time, they will then get randomized to either continue on that active treatment regimen or to convert to a matched placebo. And we will be looking for that delta, for that effect size of clinical improvement, biomarker improvement, subjective improvement, composite endpoints of physical activity, accelerometry, plus improvement in overall global assessment of function and pain and dyspnea and all these other symptom scales that we'll probably be using, and as well as exploratory analyses to see if we can achieve restoration of non-pathophysiological immune function. And that will allow us, using this enriched enrollment design, to be able to have a better chance of demonstrating an effect size if one does exist. Then the question becomes, well, what about people who don't end up achieving any clinical benefit? That now becomes a different potential subset of patients to study. But in this pilot proof of concept trial, if we can in fact show that patients who go on to switch to placebo either have a relapse of an initial improvement that they feel, just straight up go on to do worse compared to people who stay on active treatment and they get significantly better, and that is statistically and clinically significant. Now we have proof of concept that our treatment regimen, in fact, does exert a clinical benefit in this syndrome. And I'll let Dr. Yogendra and Dr. Bream talk a little bit more about what these medicines are and why we use them, the rationale, the mechanisms of action. But from my standpoint, what I hope to do is to be able to just demonstrate that, as I said, that proof of concept, to show that compared to a placebo arm, the subjects who are receiving our intervention are having significantly better outcomes and higher likelihood and I guess faster time to clinical improvement from their post-acute sequelae after COVID-19 infection.
Gotcha. So that's awesome, and I think we're all looking very forward to partnering with a good academic research institution to help put our program forward. And so a little bit about what we do. I think a lot of people always mention, "Oh, tell me more about your program," or, "Hey, Dr. Bream, it's been 6 months. My hair is still falling out. I can't taste. I can't smell. I'm still short of breath. I have palpitations. We have constant tinnitus or dizziness or brain fog. This whole constellation of symptoms. I think we were talking well over 200 symptoms that these patients are still experiencing after their COVID infection. And so what we do is, based on the work of Dr. Patterson, Dr. Bruce Patterson, who I think should win the Nobel Prize for what he has discovered. What his papers show, and I think his most recent paper, the one that Dr. Yo was referencing that should be in a peer-reviewed journal the next month or so, I think it's really a foundational paper for COVID-19. I think actually the way it's written, it's actually, I think, relatively easy to understand. I mean, for medical professionals, it's certainly easy to understand. I think, lay people could read it and have a great understanding of what he's found. But basically, what he's found is there's this group of, monocytes, they're called, the CD14, CD16 monocytes have, 73% of long COVID patients still have residual circulating, COVID protein in these non-classical monocytes. And we think that based on the expression of, CCR5 and, fractalkine on these cells, they are continuing to induce, vascular inflammation and immune dysregulation. And that's what's causing long COVID patients to continue to feel sick for months. And we have developed a panel, Dr. Patterson, based on artificial intelligence and machine learning. He's been able to develop a panel that we look at, and it measures very vast array of cytokines, IL-2, 4, 6, 8, 10, 12, VEGF, tumor necrosis alpha, INF gamma, soluble CD40 ligand, RANTES, and I think that's pretty much everything. CCL4, CCL3. And we look at all those, and based on, a lot of times I can tell you, I haven't seen a large number of COVID patients or post-COVID patients at this point. I can almost tell by people when they talk to me about what their symptoms are, I can almost predict what their profile is going to show. If somebody tells me, that they have lots of brain fog and headaches and tinnitus, I can guarantee you in general that their RANTES is going to be elevated and their soluble CD40 ligand is going to be elevated, among others. When people tell me that, a lot of patients will tell us that, hey, my veins look really big, they look dark. I can always tell you that their interleukin 8 is going to be elevated because they have a lot of vasodilation from interleukin 8. And so we can use these cytokine, the clinical manifestations combined with the cytokine panels to help precision target what we need to do to treat these patients' symptoms. And that's what we do. And that's where the expertise of folks like myself, Dr. Osgood, and Dr. Yogendra, Dr. Parikh all come into play, is that, we are very familiar with Dr. Patterson's work, what his work shows, and how we can use his research to enrich the lives of our patients who have, quite frankly, been debilitated for, up to, 18, 20 months now from post-COVID symptoms. And that's what our program entails. And so if you're interested, if you're suffering from long haulers, we want you to come visit us. Our website's www.covidlonghaulers.com. You'll get a link to register. We'll send out, I believe it comes by FedEx. You'll register to get your labs. They get sent out to you. You have your labs drawn. You send them back to either Radiance or Innovative Bio. Then your labs will be uploaded into your portal. Once your labs are uploaded to your portal, you'll reach out to schedule your appointment. If there's any issues at any point in the process, we have actually, one of the biggest things that we've expanded our programs, we've hired 3 clinical nurses who are now able to help out our patients with any snags that they have. Nursing at immunotrack.org is the email to the nursing team, and they can help you navigate through any challenges. And then, basically, we are all working diligently to open up more hours to see patients. I know we'd had a backlog of patients. We've been working through that. I know myself, Dr. Patterson, Dr. Yogendra, Dr. Osgood, we've all, we were doing 4 hours a week. I think we're all doing at least 6 to 8 hours a week. I'm doing close to 30 hours a month now, seeing patients and try to clear this backlog, because we know there's lots of patients that want to be seen. The demand is high, and we want to help as many patients as we possibly can. And so that's generally how the program works. Hopefully the wait for an appointment is, now in the, hopefully, certainly less than a month. I think less than that. But, we will certainly do everything we can to help our patients. And that's, I think, one of the great things about our programs. We have a very dedicated team, and we are all passionate about what we do. We're passionate about COVID and PASC, long COVID. And I think the difference that you'll find with us versus any other programs, we're not going to rest until we do everything we can to help you. I don't think there's anybody in our program who will tell you that there's not any physician in our program who won't go above and beyond to help you, to do everything we can to get your life back to normal when you've been debilitated from long COVID. And I think that's the difference in the program by IncellDx versus any of the other programs. So not only the dedicated physicians, but just the research that we have backing us. There's an article that came out. Ron, what paper was that article in? Talking about, this, they had like some new discovery that somebody thought that there was circulating COVID causing an immune response. And then I can't remember which article it was in. I remember NPR. So it's an NPR article. I'm like, and I tweeted at the guy, I'm like, hey man, there's a guy who's been writing these articles for months now. It's not just a theory of his anymore. We know this happens. We know this is a theory. And, we've proven this in the lab. And so, Dr. Patterson's work, certainly is, I think, way ahead of the times. And so we're pleased to work with him. But actually, speaking of that, Ron, but why don't you talk about a little bit about our expansion into to some other countries, not just United States?
Yeah, thanks, Dr. Bream. So the assay, IncellDx has partnered with SynLab. And I know we've been talking about this for a really long time. If you can imagine going and setting up labs and doing this in a different country, different continent, there's so many different hoops and things to jump through. Where we stand with that is 84 patients in a pilot in Spain just got their lab work done. Their results about a week ago. We were hoping to start the telemed consultations with them. We have 3 Spanish-speaking doctors, another group that we're sort of putting together that is going to be dealing with the European side, and especially with the Spanish patients. So there will be expansion into, my understanding is by the end of November, to the rest of the EU and Latin America. But how SynLab works is SynLab Madrid they got the full buy-in. Dr. Patterson and I have been on Zoom calls for the past 2 months with local Spanish doctors. We've been training, these are local community physicians in Spain. And right now, as of today, there are 5 doctors in Spain that are willing to use these protocols, use some of the medications and our approaches. And like I said, 84 patients have gotten their results right now. We start consultations with the Spanish patients on Friday. Or maybe Saturday of this week. So finally, if you're one of the Spanish patients that's been waiting, we just finally got the green light. I think Friday or Saturday of this week, we're going to start that. The United Kingdom, there are 1,000 patients that have registered for testing through SynLab. How initially it's going to work is all the blood goes through Madrid, and this is also Latin America. That's Mexico City, Peru, Colombia, and Brazil. All of that blood gets shipped overnight to Madrid, and over the next couple of months, SynLab is planning on opening up draw stations or major centers all over Europe, Paris, Germany, definitely the UK. There are 1,000 patients in the UK. We've also partnered up and have signed an agreement with a UK physician who obviously I'm not going to say names right now because we're going to put press releases out, but he's building a full practice. Now, he said he needs about 2 to 3 months to get his practice and get all these physicians on board. And we told him this is a public health crisis. It's really sad with the UK. I think the UK patients have it the worst because they have a system that is not really allowing doctors to really think and operate outside the box. So, but thankfully, this one consultant has jumped on board and he's forming a practice. And we told him, look, we can't wait for 2 or 3 months. There are 1,000 patients that are registered to get tested. So he's going to start seeing patients individually while he gets his practice up and running. So we got a lot of really exciting things. And this is just the IncellKind panel. We get this question about the immune subsets. A lot of the patients call it the spike protein test, and it's actually the real correct term is immune subsets, or the S1 test, which is again another term that the patients are using, and that's the test that we used on the second paper, which is now kind of wrapping up peer review, where we looked. It's using flow cytometry and looking at the non-classical monocytes, and we can look for the S1 protein. in these patients, both in long haulers and patients who unfortunately have some issues with the vaccine. We can go and look into that. So if you look at the IncellKind panel as a screening test, the immune subset is the confirmatory test. We usually have this approach with HIV where we have the ELISA as a screening and the Western blot as the confirmatory test. And what's really interesting is having, as clinicians, having this, now we have two metrics that we can use to see response to therapy and see sort of how bad your symptoms are. And so one of the other things Dr. Osgood talked about, the clinical trial, we are actually going to incorporate that. We were talking last night with Dr. Patterson and kind of putting together the rest of the clinical design. We are going to be using that as the immune subset test on the clinical trial. Because what's interesting, and Dr. Osgood, Dr. Bream, I'm sure will agree, is when patients start to feel better, not only are their cytokine markers normalizing or coming down, but we're also able to show the decrease in the S1 protein. So when patients say, look, I feel 50% better, 60% better, that obviously reflects on the cytokine profile. But in a handful of patients we're testing, and we're seeing the S1 protein start to come down. So we're definitely seeing that correlation there. And it'll be very interesting in a clinical trial to actually see what we are seeing from a clinical perspective. With that being said, where's the update with that? Again, a lot of these things just take a really long time. They have to transfer. IncellDx has one person in the lab. There's one lab tech, Brian Francisco, who does all of the immune subsets. And so he's not only responsible for doing all the research stuff and processing all the labs that our team is sending him, but he's also responsible for transferring all of that technology to the CLIA labs. And that's just what's taking us a really long time, is getting it transferred to the lab in Chicago and Los Angeles. And right now, I don't think there are any plans on having the test in Europe, but that'll probably be a couple of months away from now. So with the S1 protein test, what we are planning on doing is that probably by the end of the month, that is going to be available through Innovative and Radiance in Chicago and Los Angeles, respectively. But the test right now, they're trying to get to use the S1 protein. There's a whole patent thing, and there's a whole bunch of things that IncellDx is going to do. So what we are doing in the meantime is, starting next week, is that patients can actually pay to get this test through IncellDx. We obviously will not be able to process hundreds and hundreds and hundreds of patients because it's only Brian that's doing it, but we should be able to at least do a little bit more. And right now we're just trying to keep it for patients that are having really bad symptoms, ones that are not responding well to the therapy, whether it's both the long haulers and the post-vax patients. And why that's really an important assay, because what it's allowed us to do is, when we start talking about long COVID, there are sort of these different subgroups that we're really starting to understand. I think there's one group, and this is the majority of the patients. They had mild to moderate COVID. The virus didn't really do much destruction or damage, and they developed symptoms after this mild infection. And what happened was, it's the pathology that Dr. Patterson and our team have described with the S1 protein and those non-classical monocytes, or I always call it the garbage in the garbage trucks. Those immune cells are like garbage trucks and garbage inside of it. And if you think of, if you have garbage in a garbage truck that's been sitting there for 6, 9, 12, 18 months, whatever, there's going to be a smell that comes out of it. So the cytokines that we measure, it's a smell that's coming from those garbage trucks. And one of the things that we're starting to see is majority of the patients in our program, and when I say majority, I would say about 70 to 80% of the patients in our program, if they had a positive COVID test, most of them have the S1 protein in them. They are responding really, really well to the program, to the medications and the protocol. There's probably about 20 to 30% of patients that do not respond to treatment. And it's very interesting. Of those groups, I think there's a certain group of them that never had COVID. I think the unique thing about our program is that, there were people between January and June of last year, or July of 2020, that unfortunately didn't have access to testing. And The problem is that they might have had COVID. They may not have had COVID. We don't know. The problem is that a lot of the long COVID clinics say you need to have a positive COVID test in order to be in our program. But unfortunately, when we take that approach, there are definitely people that had COVID, didn't have a positive test, that now are not going to get the treatment. And so our approach when we put together the program, Bruce and I said we don't want to exclude those patients. So we cast this wide net. And we're also taking in patients that, quite frankly, never had COVID, and these symptoms are not. But it's really hard for us to differentiate. But the thing is, as clinicians, all of us, I think Dr. Bream and Dr. Osgood will probably attest to this, is, look, we're clinicians at the end of the day. Even if it's not COVID, we're going to try to figure it out. We all went to medical school. We're all board certified in our respective specialties. We're not going to say if it's not COVID, this is out of our scope of practice. No, we'll try to figure that out. So there's probably about 20% in that group, a certain percentage. I couldn't tell you what that number is, but quite frankly, they just didn't have COVID. There's another group of patients, and I think this is the one that I'm just a little bit cautious about talking about it too much, because I don't want to sound negative or scary. But these are patients, unfortunately, that got damaged from acute COVID, whether it's neurological, whether it's respiratory, cardiac, and whatnot. And I don't necessarily think it's a big group of patients, but I think it is something that we do need to address. And I'm starting to see those patients. And they're ones that they were healthy before COVID, definitely had a positive COVID test. They get their cytokine profile and it's normal. We do the S1 protein and they don't have any S1, but they did have a positive COVID test. So something happened to them during COVID. And we put them on a series of medications and they do not respond. And what we do in those instances, we're actually working with a whole bunch of specialists all over the country. And I will talk about one particular case from a patient that I've been very closely working with. And this patient actually had a positive COVID test, developed neurological symptoms while they had COVID. And unfortunately, these neurological symptoms persisted. So they didn't manifest themselves after COVID infection. Was on the leronlimab study, which is a monoclonal antibody developed by a small biotech company. Didn't respond to leronlimab. Was on Maravirac, ivermectin, fluvoxamine. I mean, you name it. Colchicine, prednisone, everything. Nothing. Cytokines look normal. Did an S1, did an immune subsets, there were no S1 proteins. The neurologist that we're working with did something called a neuroquant test. And unfortunately, this patient had some brain issues that, they showed signs of some Alzheimer's, and they were a very young patient, which was very startling for us. And there was some brain atrophy. Again, did this patient have this before COVID? I don't know. But that was the first time the light bulb went off in my head, and I said, okay, there's definitely some patients that are having some damage during acute phase of COVID, and it's not necessarily an immune dysfunction. So I always when I tell patients and I talk to other physicians, is any doctor that says they have a 100% success rate should be selling used cars. And we do not have a 100% success rate. I would say it's probably about 70 to 80% of patients are having a positive response. Now, the good thing is, of that group of patients, about 20 to 30% of patients have tapered off the medications. We do have patients that they're off the medications completely. They're 2-3 months now off the medications. We're just watching them, monitoring them. And that's the really exciting thing. And there's another group of patients that are having, they're on the medications, usually about weeks 3 to 6. 4 to 6, they're starting to feel better. I always say it takes about 6 to 8 weeks. We're in, no pun intended, for the long haul. 6 to 8 weeks. Now, there's one patient we put on fluvoxamine, atorvastatin, and a low-dose steroid. In 3 weeks, she said she was 90% better. This woman had brain fog, had a lot of cardiac issues, her POTS. I think she had some peripheral neuropathy too. I was working very closely with her. In 3 weeks, she came back. At the same time, there are patients they've been on medications for about 14 to 16 weeks, and they're slowly starting to turn the needle. And this is why what Dr. Osgood was talking about and Dr. Bream about the clinical trial, is, the criticism we're going to get, and rightfully so, is that is this from the medications, or are these people getting better on their own? And you know what? As a clinician, from what we're seeing, I can say, look, my clinical acumen says that it's these medications. Because why after 12 months we start medications and these patients are feeling better? Why after 16 months? But there's always the possibility that these patients are getting better on their own without the medications, without any intervention. And that's what the clinical trial is going to show, is this due to placebo, or is it actually due to these medications? So that's sort of the quick update on I know I sort of rambled on, guys, but I think someone mentioned about there was a question about lingering spike proteins hiding out in reservoirs. Okay. So I do want to address this point really quick. There are a couple of things in medicine that we have to be careful about. There are theories and hypotheses, and then there's evidence. There's concrete data. Everything we talk about, the virus, there's a replicating virus or viral reservoirs, that's a theory. That's a hypothesis. One of the hypotheses that Dr. Patterson and our team were able to show was the viral particles. That's not a new theory that had been thrown out there, and Bruce found the S1 proteins. So we can show some evidence of that. Another reason we have not found active replicating virus, because those non-classical monocytes that we found the S1 proteins in it, we did single molecule protein sequencing and next-gen sequencing on those non-classical monocytes. And the code of the whatever viral RNA particles were there did not code for the S1, meaning that there was no active replication of that S1, that these were from the initial infection when those non-classical monocytes were phagocytizing or chewing up or eating infected cells. The other thing that's very important to keep in mind is the first paper that we published showed that immune signature of not only long COVID, but also mild and moderate and severe COVID. So if you're talking about active replicating virus in long haulers, then their immune system should be looking like an active or like a mild to moderate or severe COVID. That's not what we're seeing. We're seeing a group of patients with a completely different immunology. So that's also the second point that I want to make about not being a replicating active virus. So I have to be very cautious about that. But at the same time, look, we're not saying with 100% there's no active replicating virus. I think there's nothing in medicine. There are no absolute truths in medicine. So, but we're saying what we have evidence so far is this, and we're supporting it with our findings. But at the same time, everything else is just theory and hypothesis that does need to be, more research and more investigation. So I will turn it on. I know I talked for about the last 10 minutes. I apologize.
No, I really want to hit on something really important that you said, which is like you're going to see groups pop up and things pop up where people say we have a protocol or the protocol and 100% of our patients got better. And there's no the protocol. Right? This is not a monolithic group of patients. This is not a homogeneous condition. There is no one singular protocol, and there's virtually no condition like this, especially something this complex, to which every patient you treat is going to improve. So we're not trying to make grandiose claims, and we understand that even though our clinical acumen and our sense might tell us, yes, we think that the patients are responding to our intervention and not to the natural history of the course of their disease duration or the placebo effect, we recognize that we are prone to our own biases. And this is why we are subjecting our hypothesis to a properly designed clinical trial so that we can determine whether or not this is the case. So we're not trying to make unsubstantiated claims. So I agree that you mentioned that used car statement. I think that's funny, but it's also really true that you really want to make sure that you're speaking about what you're doing in a manner that's commensurate with the level of data that you have. Personal clinical observations and anecdotes and case series and things like that are really the lowest form of clinical evidence. They can and often are the basis of clinical practice and clinical practice guidelines, but we at this point have treated this huge database of patients. We've got what we really think is a great working hypothesis in a clinical regimen that is individualized and precision medicine based, and now it's time to subject it to the highest quality, which is randomized, properly controlled, placebo-controlled, blinded trial to actually determine more factually or at a higher level of evidence whether or not it's going to hold up to that type of trial. And to just touch upon what you were saying with the monocytes and that the theory of actually why we think these patients are improving, it is the blockade of that the reduction of RANTES by the blockade of CCR5 and the antagonism of fractalkine with statins that we think is almost sort of retraining. We basically want to get the immune system to stop listening to these monocytes that are continuing to present this S1 subunit as something that has to be the source of inflammation, something that has to be fought against, that's triggering inflammation everywhere. And then in time, those monocytes go and they commit apoptosis, die off, and then we generate new monocytes and we bring down that percent of affected monocytes. And that's why we think we have that duration of time where people start to feel better. And if you too abruptly discontinue that therapy, in our experience, those patients relapse, get worse, versus if they stay on the therapy longer, they continue to improve. And that is why we have chosen this clinical trial design, and why we think this is the most appropriate design to study it, because we will actually be able to hone in on that and determine whether there is a diversion or sort of a deviation in the continued clinical course of how these patients do if they continue on the treatment regimen versus they go on to match placebo. And so that's really the key. And I know Dr. Patterson was very happy with and excited about this trial design, as am I, because I really think this is our best chance to prove concept if in fact this is working. And then once that's done, once you have a pilot trial and you've demonstrated proof of concept, then you can do the sort of the larger trials, the larger parallel arm trials, the more traditional designs to see if this is more generalizable, or whether potentially other co-therapeutics have to be added for certain patients.
And so we are excited. We know what we've been doing. We've seen the results of our patients. We know that the majority of them are getting better and making great recoveries. I talked about a guy who who I saw and graduated from the program a couple weeks ago, and it's a really awesome feeling when you get to graduate patients from the program. When I wasn't the person who followed him. I think Rom, you started him out. I think this guy basically started with us from his hospital bed, and I was just the guy. I was the one who got to taper him off over 2 visits, and he was hiking 9,000 foot mountains again. And it's just really cool that we really to follow these folks, and and like Dr. Yo was saying, it takes a long time. It's hard to undo a year's worth of disease process in a month. Like it doesn't really happen. That's why we encourage our patients that it's a marathon. It's not a sprint. There are some patients that, like Dr. Yogendra said, who you give them the medications and they seem to have relatively rapid results, but that's the exception, not the norm. I tell my patients they generally are in the program for a few months, and that we taper off the medications so that you don't have a relapse. But we're very confident in what we're doing. We're very excited, and it's just a great feeling when you get to graduate these patients from the program. And I feel confident in Dr. Patterson's work and our ability to help people. And as Dr. Osgood was saying, it's not a zero-sum game. We have lots of different medications at our disposal, and that's why I was saying whenever we are working with you, we engage in shared decision making with our patients to help figure out what medication regimen is going to be right for you. And there's a lot of different medications to choose from. They all have a similar basis, and we're trying to immunomodulate and reduce the inflammation. And there's lots of different ways that we can do that. And so each patient is unique. Each patient is different. It's a very complex disease process. But I enjoy working with a great group of people who really make a difference in patients' lives. And then, Ram, I just want to ask you, I saw a tweet recently talking about some pediatrics. Can you tell us a little bit about that?
Yeah, we actually, with the program, we don't necessarily, all of us don't really see pediatrics. We take it on a case-by-case basis. I think Dr. Patterson we work with the pediatricians, because the question is, when we start to talk about repurposing and off-labeling medications for pediatrics, what's the bandwidth for that? And Bruce has done a lot of research and work with pediatrics when he worked at Children's and at Northwestern. It's one of those things that we do see a small group of pediatric long COVID patients, and unfortunately we see some, a handful of some post, vaccine teenagers, unfortunately, that we're working with. But now we have a couple of pediatricians on board. We have one, actually a long haul doctor in Texas, who's one of our patients, who is also a pediatrician, who is willing to see pediatrics. Dr. Crevier in Illinois, he's both board certified in internal medicine and pediatrics, so he's seeing some peds cases. And now we have Dr. Robin Rose, who is on, she's based in Connecticut, but she's able to see pediatric patients, California, Florida, New York, most of the East Coast. So look, it's not a big part of our practice, but long COVID children do exist. And so that's something that, Dr. Patterson is really going to be the one really seeing most of those patients, but it's something that we are slowly addressing too. And that's why we have pediatricians on the call with Dr. Patterson, so that they can discuss, off-labeling and repurposing these medications on peds. Because like I said, they're not, people think that pediatrics are little adults, and they're not. Their physiology is completely different. How they metabolize medications are different. So, I do pediatric anesthesia all the time, and I can tell you that, their heart rate, if you ever see a kid put them on monitors, their heart rate is like at 160 beats per minute. Where if you saw that in an adult, they would say, oh, you're tachycardic, and try to give a beta blocker or some sort of medication. With a kid, that's normal, and it'll freak you out if you're not used to it. So I'm just using that as an example that kids are not little, there's this saying, oh, they're little adults or tiny adults. They're not. Their physiology, their metabolism, everything's completely different. Yeah, go ahead.
Sorry.
Sorry, go ahead.
Oh, sorry. No, I thought you paused. I don't want to cut you off. Please, I'll wait till you're.
No. I just finished my. Dr. Bream just asked me about sort of the pediatric thing, but like I said, it's only Dr. Patterson that's seeing them.
Yeah, no, I just want to say that, like, as one of the newer members of the group, it is funny, you start doing these telemedicine visits, and you have some new patients, and you're starting them on therapy, and you're like, boy, I hope this is going to work, and you're doing consultations with their prescriber, but then you actually start doing follow-ups. So I'm starting to see follow-ups, or, when I first started, of Dr. Yogendra's, Dr. Patterson's, and Dr. Bream's patients, and I'm going through their notes, I'm talking to these patients that have been in the program, and to hear people tell me, when I entered the program, I was either bedbound or really couldn't leave the house, couldn't think, couldn't work. My brain was foggy. I couldn't taste, couldn't smell. I had POTS syndrome. I couldn't walk 5 feet without my heart rate racing to, 150. And now, I'm exercising, and I'm engaging with my family and doing fun things, and I can work. And like, seeing that happen is it's a very sort of profound experience. And it's very, very rewarding to see people get that kind of clinical improvement, and to just see the deep appreciation and the ability that just the things that we take for granted, the ability to go take a deep breath and smell the cut grass and enjoy the food that we taste, and be able to concentrate on tasks at hand and work and function, and to see people who were previously healthy lose those things and everything that means to your quality of life, and then to get them back. It's just been really one of the more rewarding experiences that I've had, and I'm just very grateful to be a part of the group. And doing this trial is going to be so important to really demonstrate to what extent our therapies are causing these effect sizes. But the clinical experience thus far with the chronic COVID group has just been incredible. I'm just very proud to be part of it.
Eric, on that note, I want to just sort of just to add a piece to what you just said. When you're talking about patients improving on the program, I think it's very important that pharmacologically, some patients are going to get close to, if you want to say 100% or pre-COVID, but a good majority of people, pharmacologically, we're probably going to get you anywhere from 70 to 90% better. Just think about it. You've been chronically inflamed for several months. And one of my concerns is that there are certain people that have gotten They've gotten the immune subsets, or their cytokines have normalized. Their S1 has we've cleared the S1. Their immune system has been reset, and they're like, look, I'm feeling like 70-80% better. I can go back to work and get, like Dr. Osgood mentioned, I can get out of bed. I can start to exercise, but they're not 100%, and we acknowledge that. But I think we have to be very careful that sometimes trying to look for pharmacological using pharmacology or other medications to get you to that 100% might actually be more detrimental and may actually set you back. And I think part of it, I've used this analogy that our approach is we're putting the fire out in the forest. There's a forest fire that's been going on for 12 months, 18 months. And we're putting the fire out. And then the second part of that 20 to 30% that needs to get you back to your pre-COVID level is regrowing the forest. That's about eating well, exercising well, all of that holistic new age stuff that sometimes we roll our eyes about, but that actually has a role. And why doesn't that work for many long haulers is because you cannot grow the forest while there's a fire. So it's about, again, having a systematic approach to this. Let's put the fire out, and then let's regrow the forest. And so I think I do hear from a lot of patients that they say, well, I'm feeling 80% better. Well, you're back to work, you're playing with your kids again, you're out having drinks, and you're off the medications. Yeah, but you know what? I just still feel fatigued, and I still have this little residual brain fog. I go, yeah, you were chronically inflamed for over a year. So the problem is that you can run after these novel therapies or someone talking about certain things, and I caution them. I never say no. I never say like don't do it, but just say that might set you back because you don't know what it's doing. And the question you should always ask is, what's the mechanism? What's the mechanism? Because everyone on our team, we can tell you the mechanism of every single medication based on research, publications. Dr. Patterson, our team's first paper, the second paper describes the pathology, and now we can identify what mechanisms there are. So be very careful about some of the treatments out there. When people say, well, it could be this, it could be that, it could be this. Those are theories and hypotheses that are not proved yet in a study, in a paper, in a research. And until then, you got to take everything with a grain of salt, because we've got patients that we got to about 80-90% better, and they ran off because someone on social media said that they should go try this, and it set them tremendously back to the point that they were actually worse off than at any point of their COVID, their long haul, or even some of their post-vax issues. And Bruce and I get these text messages all the time, and we're going, well, what do you want us to do? You did something that we don't know what it did. So be very, very careful about that, because some patients, unfortunately, no matter how much we've gotten better and they got their lives, they're constantly looking for something to get them over the hump. It literally is just time at that point. But again, if you got your life back, get off the social media groups. Stop talking to people, because there is definitely that component on there, that psych component that drags you down. And unfortunately, we see that with a handful of patients. They just cannot get out of this mindset. And what happens is the medical system then loves patients like that, because you are a patient forever. And now you got all these other people that are going to say, pay for this, buy this, do this. And next thing you know, you spend $100,000 on things. So be very, very careful about some of these things that are out there, because a lot of the, you hear this with the ME/CFS, the fibromyalgia patients that have gone the last 20, 30 years going through all of these treatments, and they've never gotten better, but they've spent like $250,000 on all these therapies, and someone said do this and someone said do that. So always understand, any team, anything you're doing, understand, ask the doctor, what's your mechanism, and where is the paper, where is the publications, where are the studies to back it up? Because if they don't, then it's a theory and hypothesis, and take it with a grain of salt.
Great point.
Yeah, and I think one thing I wanted to mention is that we know, and I talk to my patients about this all the time, that we do provide, service, at the lab. We know our labs are $360. Our visits are, right around 200. We know that, the visits are expensive. And we do try to do everything we can to, minimize the cost to the patients. And I do think that's another thing that's developed in our program recently is that we have now gotten access to the CPT codes and ICD-9 codes that we can actually get your visits now reimbursed by your insurance. So that's one of the things that it's been exciting to bring on the clinical nurses for, because they can be very helpful to the patients in helping to navigate the process. So if you have Blue Cross and you want to get your visit reimbursed, we've now got the codes for that. The nursing team can help with that. And we can definitely, try to minimize the cost to you, because that's, we want to help you. We don't want to bankrupt you. And like Dr. Yogendra said, the healthcare system is set up for profit. Unfortunately, it's just how the American healthcare system works. And, we're not like that. We want to do everything we can. We want to minimize the cost to you, and, we want to help you facilitate, if you want to get reimbursed through your insurance, we will do everything we can to help minimize your out-of-pocket costs. But that's, I think, another important thing I want to talk about, that our programs, we continue to expand. We know Moraviroc is expensive. We provide all of our patients who get Moraviroc a card, myvivcard.com. That way, it takes a $1,600 medicine down to about $100. And, the rest of the medications we use in our program are all relatively inexpensive, many of them on the $4 list. So the remainder of the medications we use are, they're safe, they're FDA approved, we're repurposing them, and they're inexpensive. So I just want to make a comment about that, we know that, it can be upfront expensive, but we've done a lot of things on the back end to help minimize the cost of the patient. And we do everything we can to make the medications as inexpensive as possible as well.
That's a great point, that we're trying to help patients, and we want to do what we can to help them minimize costs. And when you're operating in this space where we're a little off the beaten path, when you go to a typical clinician's office as a patient with post-acute sequelae of COVID, long haul, whatever you want to call it, and traditionally you're going to be offered things like psychotherapy and stretching and exercise and yoga and whatever else. And if you want to try some of these more forward-thinking approaches like what we're doing, unfortunately there's a lot of desperation and there's lack of answers, and there are going to be a lot of practices out there that are going to be predatory, that are going to play upon that desperation and charge people all kinds of exorbitant amounts of money and make absurd promises that this is going to cure you and all that. And so just when you're out there, do all your research and read into everything that you're doing and explore what else is out there. We're by no means claiming that we are the one and only answer to this. There's brilliant clinicians and researchers all over the world exploring all different hypotheses and treatment angles. But if anyone is promising you things that are just way too overconfident, and they're guaranteeing you results, and they're charging you all kinds of money and frequent visits and doing things that are not based on any good evidence, as Dr. Yogendra was saying, just take caution in that. But at the same time, this sort of refusal to step outside the box and try some of these more innovative and precision medicine based approaches is unfortunate, because patients do want to try some things, and we do want to be forward, but we just want to make sure that what we're doing is based on sensible mechanisms of action and sort of plausible research, and as I keep saying, biomarker driven. We understand the mechanisms, we know the drugs that act on these mechanisms, we watch those biomarkers improve, we track that with clinical improvement. We're not just pulling out claims and making just these sort of pseudoscientific claims. So if patients out there who are suffering with this condition, be smart consumers of information and treatment therapeutic options, because unfortunately there are those out there taking advantage of that sort of desperation and despair. People that have just been ill for so long aren't getting any answers, and we don't want to see people get fleeced and end up either getting worse or no benefit. And so that's my other word of caution to people.
There's a question, and along the lines of what Eric said about the cost of the immune subsets. So the first paper that we put out, IncellDx spent $400,000 of their own money I didn't know that. Actually, Dr. Patterson didn't even know that. Chris Mehta, when they did their accounting, realized they had spent $400,000 because Bruce is all about the research and he's all about helping people. That came out of Bruce's pocket, $400,000. We're not, we're all self-funded, this project. We have no outside funding. We have no governmental funding. None of the letter organizations have helped us. And look, we're happy where things are. So the immune subset test, it'll be offered through Innovative and Radiance. Like I said, Chris is working, they're working to getting it transferred and all the assays and whatnot. The cost of that has not been determined, but for the next couple of weeks, we are going to be just charging a very nominal fee, and it's not really going to be that much. Obviously, it's going to be less than the IncellDx panel that you're getting from Radiance and Innovative, but I think it's just to cover like the resources and the reagents and the antibodies that they're using for the assay. So I think Chris is trying to put something together this week, and so we'll be able to try to get that more accessible to people. I also just want to quickly talk about the vaccine paper that we're working on. It's something that as a group we struggle with because our approach is we're not an anti-vax group. We're not trying to shut the vaccine program down like some of the other groups and other characters that are out there. We do see the benefit of the vaccine in certain groups of patients, but there's a small group of patients. I don't know the numbers. We're not doing epidemiological studies. About 10 to 15% of the patients we're seeing are, they're the post-vax patients, but that does not mean that is indication of the general public. We're not doing any population-based studies, and there's sampling bias because these patients are coming and seeing it. So we get these questions all the time of what's the percentage or how many patients, and I want to just always use caution and say that we're not doing any population-based studies, and our analysis is just based on just internal data of what we're seeing. And with that being said, there are 50 patients that are on the paper that we looked at their cytokine profiles. We've done a machine learning and sort of AI work on that. And then the second thing we studied, we took 11 out of the 50 patients, and we looked at the immune subsets. 9 out of the 11 patients, the post-vax patients, so the 11 of them, they had a negative nucleocapsid antibody, which, again, unfortunately is not the best screening test, but it's the only one that's easily accessible for patients. And it's suggestive that maybe they didn't have COVID before. Again, it's not 100%. You might have had COVID and you don't have antibodies for any of the viral particles, especially viral pieces, especially the nucleocapsid. But it's the best test we had, and so we took 11 of them. We screened them for the nucleocapsid antibody. They were negative. Some of them had multiple negative PCRs, never had any signs or symptoms of COVID in the past year and a half. And we looked at their S1, and all of them had the vaccine. And 9 out of the 11 had the S1 protein in them. The highest number we tested was someone who was in the AstraZeneca trial, who was close to 60% of these patients monocytes expressed S1 proteins. So most of the post-vax patients are anywhere from about 20 to 40%. The highest has been 60. The second highest was 55%. And someone mentioned about the VEGF. Yes. When looking, I have about 100 profiles that I've looked at myself on my Excel spreadsheet. But I think we're only going to publish about 50 to 75 just because of the amount of work it's taking me to put that together. But out of that 50, I would say that maybe 5 have elevations in VEGF. The rest of them actually have normal VEGF levels. Actually, it's so low that it's not even picking up on the assay. The post-vax is driven by, most of them are driven by RANTES and SCD40L, SCD40 platelet activator. RANTES is a chemokine that is secreted by T cells, macrophages, platelets, endothelial cells, epithelial cells. Again, suggestive that you're talking about some vascular inflammation that is causing platelet activation. So there's a vascular component to that. Now, interestingly enough, some of the post-vax patients have elevations in TNF alpha, and we see a correlation between the neurological symptoms and TNF alpha that is really starting to manifest itself. And there is literature that suggests that TNF alpha can cause some of these symptoms, or the neurological symptoms, as seen in some of the post-vax patients. And then the other one is interleukin 6, which has been studied extensively in arthritis. A lot of like tocilizumab and saralimumab and other medications have been targeting IL-6 for rheumatoid arthritis, and we're seeing some of the post-vax patients that have joint pain and myalgias are having some component of IL-6. And again, you're seeing the same thing with the long haul group, but very specifically, since we're talking about the post-vax. And I think for us, our thing is, look, I think we can get people better. If you're looking at the denominator, there's, I think, over 200 million Americans have gotten vaccinated, have gotten at least one dose. I think there's over 400 million doses of the vaccine, or 350 million. I forget the number off the top of my head. So you're looking at a huge denominator. And what the numerator is I don't know. But I think it's small enough not to cause widespread panic, but it's still large enough that we want to investigate, study it, and try to help those people. And I think that's sort of the approach of our group. And I'll let Dr. Bream and Dr. Osgood, sort of, because they're seeing also a lot of these patients. And I know Dr. Bream, he's seeing some of these patients in his emergency room. And by the way, everyone in our group, including our nurses, have all been vaccinated. Everyone at IncellDx has been vaccinated. In fact, some of us have even gotten our booster. So, that goes to show you, here we are talking about this issue, and none of us have really had any issues, but we acknowledge it and we're trying to do something about it. So I'll let Dr. Osgood and Dr. Bream comment on that.
Yeah, I mean, we're studying a rare phenomenon, and we can be adults and understand that it's a rare phenomenon, but that doesn't mean that patients experiencing it aren't deserving of having scientists and doctors look into the phenomenon to try to figure it out, get to the bottom of the pathophysiology, figure out how to manage it and treat it. But as you said, the denominator, the number of patients, the number of both clinical trials as well as prospective cohort studies that are really not picking up, this much signal, and people are getting it compared to control groups, which is showing us this is something that's very rare. And therefore, considering the fact that these vaccines are extremely effective at keeping people out of the hospital, out of the morgue, and the overwhelming majority of people receiving the vaccines are not having anything like this. Everyone in the group will advise patients, if you have not been immunized against COVID-19, if you have not been vaccinated, to get vaccinated. Another thing that often comes up in people dealing with long haul, or maybe on the tail end of it, who maybe got their vaccines a long time ago, maybe if they're immunocompromised, maybe they got J&J, their antibodies are low, whatever it might be, and they're asking, well, should I get the booster? And myself, and I know I've talked to Dr. Parikh about this, we're telling them yes, because if you go out there and you get COVID-19 again, you actually get infected, that could tremendously set you back. And so the net effect of vaccines is to protect you from post-acute sequelae of COVID and from this long haul syndrome. So even though a very low percentage of patients in this rare phenomenon are experiencing this syndrome, we just want to make sure that we can actually talk about this and be mature and be adults about it and be able to study it, understand the mechanisms, how to treat it, and understand that we simultaneously are very in favor of patients getting vaccinated to protect them against this horrible disease, and the fact that people who are getting COVID long haul from the viral infection are often extremely, extremely difficult to treat and to get better, although a lot of, and we do have a lot of success stories, whereas the patients with these post-vaccine illnesses really seem to be responding pretty robustly to our treatment protocols. And so I think that's like sort of an important takeaway, and to understand that we are very much in favor. We do not want people to be out there not vaccinated against this disease. That's extremely dangerous. We see how horrible, landing in the hospital, ending up on potentially a ventilator, passing it on to someone who's immunocompromised, potentially having them go onto the hospital or possibly die. as a species, as a society, we have to get past this pandemic. We have to get the population vaccinated. At the same time, we want to study this phenomenon because we want to help this small group of patients get better from this condition.
Right. And so, so the backgrounds here, I'm not sure if I noticed, Dr. Yogendra is an anesthesiologist, and Dr. Osgood is the critical care intensivist.
No, I'm an internist. I'm not an intensivist, but thanks.
And then I am, an ER physician. And so, what we do is, we see, basically, we're the three faces you don't want to see from COVID-19. That means by the time you've made it to us, you're severely ill. By the time Dr. Yogendra is coming to your bedside, they're putting a breathing tube in. With me, you're just seeing the acute phase of that. We're trying to just stabilize you to get you to Dr. Osgood and to hopefully never get you to Dr. Yogendra. And so it is important. We do know that and we don't run from the fact that there are some issues with the vaccine. Like I said, I do see issues, because when people do have effects from the vaccine, a lot of times they come to the emergency department. And so I do see those patients. The overwhelming majority of them, I'm able to discharge home with symptomatic treatment and reassurance. But there are patients who have had debilitating effects, and we do think it's important to understand those effects and how to mitigate those effects. And I think the frustration is, we acknowledge that these things happen, and we just have to make sure that they're being addressed in a rational and scientific way. And I think that the big thing we do is we acknowledge that it's an issue, and that it's an issue that can't be taken lightly. What if somebody had not decided to study a group of patients in China who seem to be coming in with a rare form of pneumonia, with peripheral opacities. At one point, COVID was rare. What if some doctors in China had not looked into that? Or, is this kind of how we see these things? Everything starts out as rare, and then we have to, or at least new disease process. We had, HIV. What if, doctors didn't start, investigating, these patients coming this sort of rare, cases, this rare cancer, and figure out how they got there. So, we have to approach this from a science perspective, and, we will do that, and we will continue to treat all patients equally. And whether you've been vaccinated, unvaccinated, we're happy to help you with the issues that you've dealt with your COVID experience. And I think we all take our Hippocratic Oath very seriously, to help everybody, and that's why we're here. But we will continue to investigate these patients, to study them, to see how we can best help them. And, that's definitely what we're here for. So anyway, well, I know we're about an hour and 15 minutes in, and everybody's attention spans are, probably starting to expire here. And so I want to thank everybody for joining us tonight. A huge amount of praise for Dr. Osgood and Dr. Yogendra for everything they do. And really, for Dr. Yogendra and Dr. Patterson, I mean, I'm sure Dr. Yogendra could tell you, like, all the, the blood, sweat, and tears he's put into this program. He and Bruce have really built this from the ground up, with the research and building out the program, and building out the treatments, and recruiting the physicians, expanding to other countries. This is a huge undertaking, and now we're on the cusp of something else new and exciting with an academic research organization who's going to help us to hopefully to validate our program. And it's just an absolutely huge step forward for the program. And I just want to say thank you to Dr. Yo and Dr. Patterson, all the research they do in the lab, the putting together this program. I literally, without Bruce and Ram, there is no long COVID program through IncellDx. And so I'm just very, very appreciative of them. I'm happy that I'll be able to unite with them and Dr. Osgood, Dr. Kreimer, Dr. Parikh, and to work with them and be colleagues and associates, and to continue to help patients. So Ram, a huge thank you to you for everything that you've done, all you've sacrificed to help these patients. And I know Ram will tell you, a lot of these patients, they have his personal phone number. I mean, he's talked through them all hours of the night. he's just a huge advocate for his patients, a huge advocate for this program. And we owe a huge amount of gratitude to Dr. Yo. All the long COVID patients do, because he has just done a tremendous amount of work for this program. And Dr. Yo, we greatly appreciate you.
I'll second that.
Thanks, guys. No, I appreciate it. I appreciate the kind words, and also, look, it's a team effort, and you guys just jumping in after what we started, it just really, you guys just took it to a whole different level, and all the expertise and things, and that's what it is doctors don't collaborate. We don't talk to each other. It's the one thing I learned. I say that over and over again. The one thing that I also want the patients to know is, we have Dr. Bream, Osgood, Parikh, 11 doctors now on our team with 3 amazing nurses that the response time has gotten better. We're building the plane as we're flying it. I also want to give recognition to a lot of the PCPs that are out there. And one of the things that when Bruce and I put this program together last fall, Bruce and I doctors would tell us to go F off. The number of rude emails both of us got, it was actually kind of disheartening. And what we said to ourselves was, I remember having a conversation with Bruce and said, let's just do it ourselves. Let's put together a group of doctors. And over the past several months, we brought, we're able to bring Dr. Bream, Dr. Osgood's expertise, Dr. Kreimer's expertise, and many other doctors now, and also build a whole network of doctors all over the country that just keep on just getting added. Like literally every day I'm on the phone with doctors saying, we heard about this. You guys are only yet. We're in. We've got a Slack group of doctors. This Thursday night, we do a doctors only meeting where we do case presentations. That's how we met this doctor from this big academic center. He's always on these calls with us, and he's treating his patients in his big long COVID clinic. And so part of it is this is really a movement. And, there is actually Kay Smythe is actually going to be writing a book about our program. She started working on that, and she's pitching this story, because it's not about the research. It's not about me or Bruce or Eric or John or any of us. It's really about how are we going to transform healthcare and medicine, and so many different obstacles. We are the large elephant in the room that everyone knows exists, but no one wants to acknowledge, and we don't give a damn. As Bruce says, we're on the dark side because we're in the private sector. We're not affiliated with major academic centers. I mean, who the hell is John Bream or Eric Osgood? Who are these guys? Where's their fancy emails, or where's their white coats and their bow ties? So I can tell you this right now, they're absolutely intelligent, brilliant doctors. They are also huge patient advocates. And I've talked to many of you guys, and I've said, oh yeah, you're with Dr. Bream or you're with Osgood. I said, those dudes are going to run through a brick wall for you guys. And if they don't have the answers, they're going to find it. They're going to find someone that has the answers for you. So I'm really grateful you guys are part of this program. You've made it tremendously better. I don't have to tell you that because our patients are telling us that. So guys, thanks a lot. Thanks, John, for putting this together and inviting me on.
You're welcome.
Yeah, thank you.
Yeah, thank you. And then I think some December. We think we should be opening December slots soon. I think availability should be coming open. So if you're looking for an appointment with us, just keep checking in. And if you can't find an appointment time, we will work with you to find something. So again, thank you guys so much. Thank you for joining us tonight. And if you're, we'll be chatting again soon.
Thanks so much, guys.
Thank you.
Thanks.
Bubba, are we off? Are we backstage only, Bubba?